everybody. I'm Catherine Kolkmeyer. I'm with the Health Science Consortium, and I'm on the steering committee for Rebuilding for Learning this year. And welcome everybody to our session on ACEs. If you were here last year, you know that this was a topic that we started at our previous Rebuilding for Learning session, and wanted to continue some of it this time around to talk a little bit more about adverse childhood experiences and then trauma-informed care response to that. Some of the training that they're going to be talking about today is part of a venture grant from the United Way, which is putting some funding towards building resilient children. And so this trauma-informed care training is one of the ways that that's going to be taking place. And Lacie Ketelhut from the National Child Protection and Training Center at Gundersen, and Cindy Leis, who's a behavioral health nurse at Gundersen Health System, will both be talking a little bit more about adverse childhood experiences and trauma-informed care and some of the changes that we can make to be a healthier and more informed community. So I'll leave it to you then.
Mm-hmm.
Have a great session.
Thanks. Yes, so I work with the Gundersen National Child Protection Training Center, and some of you, I don't recognize too many faces in here. I've worked in the lacrosse community for the last 7-8 years, focusing on community work, preventing risky youth behaviors. A lot of that was alcohol, substance focused, and that was kind of my realm. And now working with Gundersen, I'm working in the area of prevention of child abuse. And that's where we want to talk about early experiences and how can we grow healthy youth, safe youth. And that's really the focus, is looking at growing that. And the conversation on ACEs, which is what we tend to roll off our tongue for, it means adverse childhood experiences. We'll say ACEs, and that's what we're referring to. We're going to explain a little bit what it is the general focus of conversation that's been in our community for a while, yet we recognize that even in this room and within our professional base, there is a huge continuum of where people are at with this information. Some, when I said ACEs, will think it is the aces of a card. Just that's the first thing that comes into head of where we're talking about cards. And some are, I've heard this, I know what it is, and I'm even starting to do some action on it, which we look at as trauma-informed care. So all over, and we recognize that. What we tried to put together and through the venture grant process is develop a training that can get us all aligned at some level. So we want to provide foundational information because we all need that. Even if you heard this about ACEs and you're familiar with the topic, we still need a foundational base of knowledge. That's the first step. After that, we can all start moving and we'll all start talking the same language, which when we're talking about language, it's going to drive some of our behavior and actions. But we also want to have something, okay, so now what can we do? What are some actions? And we tried to build that into the training too. So today, we're going to focus on a journey. And that's kind of why we titled it From Adverse Childhood Experiences to an Adjusted Community Expertise. Because when we're talking about growing safe and healthy youth, it is a journey. And that's what our community is on. The flavor of today, when everyone, our main speakers, when Randy was talking, when our mayor was talking, was we are at this point, a really exciting point in our community where we're starting to look towards action. And we all need to be having this conversation. And it's what we know about ACEs and what we have learned about early experiences in childhood translate to we need to adjust our practices and what we're doing so we can better intervene or better work, better grow safe and healthy youth. So that's where the adjusted part comes in. And this is a little bit of continuing the journey. How did we get here? We got here through looking at behaviors. I mentioned my work was in the community. I focused on prevention of underage drinking, risky drinking, smoking, violence. Really, the behaviors was our focus for the longest time. And I asked Regina to send me the last 5 invitations to the summit, just because I wanted to see our progression as a community, which was kind of interesting. I just picked out in the beginning in 2011, it was a call to action for organizations when we've noticed the problems, we've noticed the issues, and we need to call to action. And then for this year, it was continuing our journey as a community, a responsive community, compassionate community. So we've had a call to action, and as professionals in this area, I think that's really what we've done. We did not accept these behaviors as the status quo. We didn't think, well, every child every student who's 18, well, they all do risky drinking, or they're all having some issues with depression. That's very normal. We didn't accept that as the normal child, the normal behavior. Instead, we're like, what can we do to prevent it? What can we do to look upstream? Shift our focus from those behaviors. Some of you may have heard the example of, and in public health, this is a common example. If you have a river and people are drinking from the river and they're getting sick and they come to you as the doctor, you can treat them, and you need to treat them, and you can give them medicine and make them feel better. But if you just went upstream, you could find, why are they getting sick? And if we hit it there, then we don't have to deal with any of this down here. And that's ACEs. We're now switching and moving. We've switched our focus from these behaviors, which need interventions, and they need to be looked at, but what can we also do upstream so that we can fix it or work on it there? And that's the exciting part. I agree with what was said. I actually was hoping to talk about that in here too, but what was said this morning was we're on like a change. And I think it's really exciting that our community is at this point where we're going to talk about the information, but we are making changes. And if you've worked in this community for the past 5 years, you can even see some of those changes playing out right now. It's also challenging because there's no blueprint on how to do it. When we're talking about trauma and trauma-informed care, there's no 1, 2, 3 and done. So it's challenging, but we are making progress, and I think we are the people making the action. It's pretty exciting to see. So that's where we come in. Today we're going to do a little bit on ACEs, the ACE study, describing it and going through what that means in impact, a little bit on trauma-informed care, and then we have some training. We'll describe the training offerings that we can provide to the community through the support of the United Way grant. So 4 things to remember. We're going to talk a little bit about the ACE study, and 4 things that I would like you to think of as Cindy takes you through a study that really has changed the way that we look as in the health profession at behaviors, problem behaviors. It's really changed the landscape a lot, even in public health. So she's going to take you through that study. And 4 things that I want you to think about is fire together, wire together. What we have learned these 4 things from the ACE research, adverse childhood experiences, is the brain is directly impacted by the experiences we have as a young person. And it's foundational. Our skills and our capabilities as adults all stem back to those experiences, is what we know. The brain, what fires together becomes the wired pathway. We'll talk about that. Experiences matter. And trauma-informed care is a lot of changing the perspective. So it's changing, you might have heard, not what's wrong with you, but what happened to you. And what's wrong with you is looking at the behavior as the problem. What happened to you is now looking at those behaviors as symptoms. It's a change. And if we change our perspective, we're going to change our language. If we change our language, we're going to change our actions. And that's what we hope to start to stimulate here in our community. Well, it already has been started, but we want to continue it and make it stronger. And then plasticity is important, because even though the topic of things that can happen as a child can be really hard, and for some even in here, you've experienced some of the ACEs that will show. But there's hope, because the brain can learn new ways and can change, and we can still foster resilience by looking at the positive. So there's even hope amidst the ACEs and different things. So let's go into our study, and this is kind of what has started this whole conversation off.
So I'm really excited to be a part of this as well. From the medical side of it, inpatient behavioral health at Gundersen, we took on this in 2012. So before we built our new building, this was kind of the philosophy we were taking on, and did a lot of education with our staff, and really took a look at our new building and designed it with a trauma-informed care approach. If you were in our old building at all, ever, it was, for lack of a better term, very prison-like. It was very drab, had a lot of glass walls, partitions that separated staff from the patients, versus our new inpatient building is more open. It's got nice warm colors, a lot of natural lighting. We took down those barriers, so really made a change on our environment. as well as, like Lacey's talked about, really shifted our perspective to think about what's happened to our patients in the past and not what's wrong with them. Personally, I get excited about this because while I've learned all about it in the professional world and presented it that way, my husband and my daughter are both educators and deal with little kids. So I tend to talk a lot about it at home and again, how to kind of make those changes and think about it upstream and making a difference there. So the ACE study was actually one of the largest studies ever done to kind of correlate those adverse childhood experiences and later in life adult health problems. So even though that wasn't necessarily the initial focus, it started with a physician in the preventative health department at Kaiser Permanente, Dr. Vincent Folletti, who was running a program for obesity and weight loss. And while his patients were being fairly successful at their weight loss, he had a lot of them that were dropping out of the program, and he couldn't understand why that was happening. So he kind of took a deeper dive and started asking a bunch of questions, and he found a commonality among those patients that they had experienced some adverse childhood situations. He was then speaking at a conference somewhere, and enter Dr. Robert Anda, who was from the CDC, or Center for Disease Control, who was also looking at, through the VA patient population, the psychosocial reasons for his patients adopting health risk behaviors. So the two of them got together and did this collaborative effort to do this ACE study. And they took a look at, between the years of 1995 and 1997, they surveyed over 17,000 people and then continued the surveys after that. And they asked them these 10 questions. So these are the 10 ACE survey questions, and they basically focus on 3 areas: abuse, neglect, and then household dysfunction. And you answer yes or no to them. For every yes, you have a positive ACE score. So maximum score would be 10. And it's really focusing on the experience, not the frequency or the severity, just whether or not you had the experience. Demographically on the study, again, on over 17,000 participants, you can kind of see the breakup related to gender, race, age, and education. The demographics really point towards a kind of normal community. All of them were employed, all of them had insurance, the majority of them had a high school education, some of them had a college education, and really, again, related to normal communities. So you can't look at this and say, well, it doesn't happen in my community, because it's the makeup of our communities. They found a lot of surprises. So statistically, the majority of people said they had experienced at least one of those ACEs. They also found that those ACEs came in clusters. So if you had experienced one, you were likely to have experienced another one as well. They also found that 25% of the group had experienced 4 or more. So on that list of 10, 25% of those 17,000 people had experienced 4 or more ACEs. And that provided them with kind of a cumulative effect. So the more ACEs that a person had, the more health problems they were experiencing as an adult. So again, when you think about the relationship, there was a significant number of people that had experienced 4 or more ACEs. So what about those health problems then? Kind of speaks back to that looking upstream. So as in my role as a medical person, we deal a lot with those health problems. We deal with diabetes and heart disease and COPD and obesity, and kind of deal with that problem, give the medications, instead of looking at, well, what's been going on in your life that would lead you to experience these health problems. So it's kind of, again, opened up the doorway for us to think differently. This is what we call the ACE triangle, and it kind of sums it up all in a nutshell. So it's taking a look at your lifetime from conception all the way to death, starting with those adverse childhood experiences. So again, those situations of abuse, neglect, or household dysfunction. Those experiences create disrupted neurodevelopment. So they cause changes in the makeup of the brain, change the chemical makeup, change the development of the brain. Those disrupted neurodevelopment situations create social, emotional, and cognitive impairments. So the ability to learn, the ability to kind of learn skills and move them from one situation to the next to handle stress is something that is very difficult for people who have experienced a lot of ACEs. Those social, emotional, and cognitive impairments then lead to the adoption of health risk behaviors. It's a way to cope. So you could easily think about smoking. I've had a lot of ACEs in my life. My neurodevelopment has been kind of disrupted because of that. Then I have all these other problems going on. I'm not sure what to do about them, so I take up smoking as a coping mechanism. Well, what happens when you smoke? If you smoke for a long time, you get asthma, which can lead to COPD, you might get lung cancer. So those health risk behaviors then lead to disease, disability, and increased social problems, which then just leads to an early death. And not early death by suicide, but early death because of the medical problems. The ACE study showed that people who had responded to 6 or more ACEs died 20 years earlier than those that had 0 ACEs. So that's a pretty significant thing to think about. So how about that brain building? This is kind of a nice little video that takes a look at the development and building a healthy brain.
That was my key.
Science tells us that the experiences we have in the first years of our lives actually affect the physical architecture of the developing brain. This means that brains aren't just born, they're also built over time based on our experiences. Just as a house needs a sturdy foundation to support the walls and roof, a brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain. Building a sturdy foundation in the earliest years provides a good base for a lifetime of good mental function and better overall health. So just how is a solid brain foundation built and maintained in a developing child? One way is through what brain experts call serve and return interactions. Imagine a tennis match between a caregiver and a child, but instead of hitting a ball back and forth across a net, various forms of communication pass between the two. From eye contact to touch, from singing to simple games like peekaboo. These interactions, repeated throughout a young person's developing years, are the bricks that build a healthy foundation for all future development. But another kind of childhood experience shapes brain development too, and that's stress. Good kinds of stress, like meeting new people or studying for a test, are healthy for development because they prepare kids to cope with future challenges. Another kind of stress, called toxic stress, is bad for brain development. If a child is exposed to serious, ongoing hardships like abuse and neglect, and he has no other caregiver in his life to provide support, the basic structures of his developing brain may be damaged. Without a sturdy foundation to properly support future development, he is at risk for a lifetime of health problems, development issues, even addiction. It's possible to fix some of the damage of toxic stress later on, but it's easier, more effective, and less expensive to build solid brain architecture in the first place. One of the things that sturdy brain architecture supports is the development of basic emotional and social skills, an important group of skills which scientists call executive function and self-regulation can be thought of like air traffic control in the child's mental airspace. Think of a young child's brain as the control tower at a busy airport. All those planes landing and taking off and all of the support systems on the ground simultaneously demand the controller's attention to avoid a crash. It's the same with a young child learning to pay attention, plan ahead and remember, and follow lots of rules. Like all of us, kids have to react to things happening in the world around them, while also dealing with worries, temptations, and obligations on their minds. As these demands for attention pile up, air traffic control helps a child regulate the flow of information, prioritize tasks, and above all, find ways to manage stress and avoid mental collisions along the way. Having this ability is a necessity for positive and level mental health. Developing effective air traffic control, overcoming toxic stress, and building solid brain architecture are things kids can't do on their own. And since strong societies are made up of healthy, contributing individuals, it's up to us as a community to make sure all young people have the kinds of nurturing experiences they need for positive development. To build better futures, we need to build better brains.
So the things that they talk about in there, the high-level executive functioning and the self-regulation, that happens over time. So the timing of the traumatic experiences for a child plays a big part in that building of the healthy brain. So think of the brain, it develops over time. It develops from the inside out, and it develops from the back to the front. So if you think about self-regulation, that happens kind of deep within inside the brain, and the high-level functioning happens in your frontal cortex, which is going to be kind of late to develop. So if the child experiences those traumas early in their life when that self-regulation is just developing, then it creates a situation where they have no idea how to do that. And then if it continues over time where their frontal lobe is developing, where that executive function happens, they lose that skill as well. So when we think about that, this is really a nice view of that from a biological standpoint. So this is a PET scan. And what we do in a PET scan is we inject dye and we take pictures. And what we want to see is what you see on the left-hand side, that healthy brain, a lot of color and a lot of very bright color. We want to see those oranges and yellows. That tells us that there's activity going on there. On the other side, you see the picture of an abused brain. So over here, and you can see a lot less color, and in some areas we're totally lacking color altogether. So the child has no ability to do that self-regulation or that executive functioning because of their early trauma that they've experienced. So we want to intervene, like Lacie said, early in that stream to try to create situations where the child can have better options, better experiences to develop that healthier brain.
So we use that ACE triangle to kind of frame our work as professionals and a little bit more on the brain because it's so key into the experiences we have that they matter and the fire together, wire together. So I like to think of a field that's just here in Wisconsin was just covered in snow, our first snowfall. Just that clean white, that's like that neutral slate of a brain. And you can think of that like a brain and how a brain develops. Fire together, wire together. So somebody comes along and they're gonna snowshoe or they're gonna cross-country ski across that field, and what's left? The tracks, the pathways. Those are the experiences. And the more somebody would ski in those paths, the more ingrained they become. And that's how the brain develops, really to anticipate the world it is experiencing. Am I experiencing and anticipating a safe world, or am I anticipating more of a dangerous world? And the brain, what we know from our research and what we're seeing, and this is still a field that's having more and more research added to it, is that brain development is so key into later life, health, later how we adapt in our abilities. So I like to think of that as a good example for the brain and those pathways. What experiences happen, the brain becomes wired together to experience it and anticipate the world for that. So this is another example. Think of a big city and the type of transportation system they have in a big city. And there's a lot of different ways to get from point A to point B. You can take a lot of different directions, bridges, roads, on-ramps, off-ramps, a lot of different ways. And this can represent a healthy brain. A healthy brain that developed is going to have a lot of pathways, a lot of good experiences that I can choose and decide which is the best route for me to get to where I want to go. So think of when you're in your staff meeting, any staff meeting that you have, and the person across from you, one of your colleagues, says something really stupid. And what do? What's your response? You have choices. You can respond. You might consider, oh, I've had enough and I really just want to smack you right now. It crosses your mind, then you're like, no, bad idea. Not going to do that. You could think, well, I will just talk to you with my friend, other coworker after the meeting, talk about you and how that was a bad idea. Or I can just choose to ignore it and go on and think about, okay, that's where you're coming from. I can accept that and I can still move on. Those are three very different choices. And a healthy brain is able to think of the different pathways and decide, okay, option A, B, or C, and choose. Also think in a city how much construction is going on. Just like here, right in La Crosse, we're not a big city, but we have construction. We continue to improve our pathways. We continue to refine them. This is working, let's keep doing it. Let's make it better. So it's a good example for that. Another example is think of big city. I just got back from Boston, went to Boston for a conference, and I didn't drive in downtown Boston. Thank God, it would have been awful. But I chose the little shared van service to get there. So many of you probably have gone to different conferences, and you go in like a taxi or a shared van, and they are nuts how they can drive down there, but they're comfortable easily. They don't think about it. I was talking to my husband on the way, and it's like, I gotta go. I just gotta hang on and pay attention to how close and how we're getting, but we are weaving in and out and like going here, and you think there's no way, and you're just a passenger. But the driver, he drives that every day. He's so comfortable, and I can just choose this route, and I know where I need to go in order to get to point B, and I'll get you there. It's very comfortable for them. But put somebody who is more from a rural development, rural area, and ask them to drive in downtown Boston, how hard is that going to be? How stressful is that going to be? Challenging. And yet we do that every day with people that we work with when we have that traumatized brain that we know is impacted, and we ask them and we place them in downtown Boston and say, okay, now drive. And it's very challenging, and we're expecting expectations out of capabilities that are limited. It's just a good thing. And I think if you were going to have somebody practice and get comfortable with driving in downtown Boston, would you have them practice during rush hour and say go and get where you need to go, or would you have them practice at times that aren't as busy? You would need to practice. You would need time to be comfortable with that. And what we see in a traumatized brain, this can just represent it, is just more of limited options. There's one route. This is what I have learned how to respond. This is what works for me, whether it actually gets a good outcome or not. This is what I do. Becomes just more limited in that ability to choose and make more options. It's more of a one route kind of system. And if we ask and we place that person and ask them to do things that they just don't have that infrastructure to do, then we get frustrated as professionals, and they get frustrated because they can't do something that they think they should do. But brain development is so key in this discussion, yet it's hard because you can't see somebody's brain and see how good it is or how healthy it is. It's very abstract thinking, yet it's so critical. And we can see it through scans and research, but when it comes to actually working one-on-one with somebody, we don't see their brain. But it's important to remember a traumatized brain has been impacted and is different. But this is also where you can have an undeveloped area can become more developed. More pathways can be created, more roads can be developed. And that's with the plasticity of the brain. It can be improved. And so there's hope, even though maybe somebody had a lot of experiences that were negative in their childhood, there's still hope that we can work and we can grow from here and we can still improve. So I like to think of just the different examples, key with brain, because then we know that those experiences, lead to the social, emotional, and cognitive abilities. They're less capable, kind of diminished. This is the part where we now start to see it, and we start to deal with it and work with it. So if we're ticking up that triangle, we know average childhood experiences, then we have brain development is impacted, and then we start to see limited social, emotional, and cognitive abilities. The ability to problem solve, to reason, the ability to be a good friend, to use those friendship skills. If you're somebody who works with a younger population or kiddos, can struggle with how do I interact with a peer, or how do I interact with adults or authority, and emotional. We see that can be some of the behaviors, and we start to see more aggressive behavior, different things there. So that then all translates into the risky behaviors that we see, which a lot of things. We know that with ACEs, the more ACEs somebody has, the more experiences they've been exposed to, directly relates to the risk, an increased risk. It's not a destiny, but there's an increased risk that we're going to see some of these behavior problems. And these are the public health problems that we continue to work with, and we need to work with because they need to be addressed. But we know that the common link often, not all the times, but often it stems to what happened in early life. So that's that we still need to put our focus there, but we also want to start looking ahead and what can we do. So then we see the behaviors. I have a little bit, this is the La Crosse County Youth Risk Behavior Survey results. We take a survey every 2 years, and this 2015 data is hot off the press. It was just done this last spring, 2015, where we surveyed our local high schools and compiled the data, and they give us answers to questions. These were just some notable trends, because we have data now from this county-wide survey from 2010, 2013, and now 2015. We are seeing a lot of progress in different things. We're seeing alcohol use trend down in our youth. Smoking is trending down. Ever having sex or risky sexual behaviors, that was trending down. So we are seeing highlights. I only put a few up there, but we ask, like, I think it's almost, I know it's at least 99 questions, if not a few more. So you can get a lot from it. But what we are seeing is trends going where we don't want them to go in relation to social connections and mental health. And this is a complex issue. There's not one thing that we can point to say why this is happening. I think it's from a lot of different factors, but this really, what it is it's just a snapshot in time for us and helps us give a marker of work that we need to do. So if you think of alcohol and tobacco, how many resources and how long have we thrown our resources in there? And we're seeing results. It's trending down just like we want it to do. And now think in our community, the discussions we're having about mental health, mental illness, the signs of illness, different things with that social, emotional building. Now we're starting to put more resources there, and hopefully we can see some of these trend the way we want them to. Thoughts on this as you look at this data? Anything for you? There is more, and you can get the survey. It's open to public, the results. Tracy Hurlitsky at CISA4 coordinates the county-wide survey, and all of our schools have participated. I believe it's just the public schools, not private, but this is something you can get more data and categories. It's just a good snapshot, and it's good to start the discussion for us more than anything. Yes?
I have a question. The 10 factors that you listed, do you think that if one of those factors had just been something congenital problems, something like that, health problems, that the trends would have been the same? Those are more like emotional impacted or abuse or deliberate somehow. If you take that element off, do you think that those factors would be similar?
Well, like we know they come in clusters, some, so you can let me know if I've addressed kind of what you're getting at, but like we'll see suicide. We know there's an increased risk for suicide, but what comes along with suicide can be other factors or other risky behaviors. There might be illicit drug use or those risky behaviors.
No, I'm asking if the adverse childhood experience were a physical disability or a health
If it was labeled that way?
problem or something, would these kinds of outcomes be similar? Or did you just not study that, so you don't know? Could that be an 11th factor along with the 10?
It were
It wasn't in the study, right? Do you think that would be a factor that would result in the same kind of outcomes? Or you just don't know?
I'm not sure. I don't think. Do you have thoughts on?
I don't know either. The only thing I can think of is those 10 questions came from Dr. Folletti's conversations with his patients that were dropping out. So I it's an assumption, but I would assume that in those people he was dealing with, physical disabilities did not come up as a commonality amongst them, and that's why that was not included in those 10 questions.
Okay.
That
My guess is there's probably some studies out there, because depending on how chronic the illness is, and then the things that are connected to how that person deals with the illness. I think that the difficulty is, or the thing about the ACE is it's all about what happened prior to 18. So depending on what you wanted to look at, I think it would be, it's a big hypothesis that you have, which is, interesting, but it's just too different.
And people I know have asked the question, could there be more ACEs than just the 10? If that's also what, these were the 10 that were asked, and this is what our research is based off of, but trauma and adverse childhood experiences are such a complex issue. There sure could be other risk factors that just weren't included in the 10. I don't have the research to say which ones, but I think it's a very valid question and open to discussion of what else could contribute to something. I don't think these 10 are the only, but they are the 10 from the original.
So of the 10 that you have listed, I tried to write them down, is there any weight with one more than the other? Meaning, like, maybe I have one ACE and it's an incarcerated parent. But maybe person number 2 has one ACE and it's sexual abuse. Is there more weight that is given when you are doing that type of work? Because to me, there's a severity difference.
And in anything that I've read, I've not seen that, and I go back to 2, it's also just the experience, not the frequency or the severity. Because you could argue that, sexual abuse is worse than an incarcerated parent, but one episode of sexual abuse is not as bad as repeated, or, so yeah, I don't think there's anything out there, at least not in this study. There's maybe other studies that took a look at that more, but yeah, it's interesting as well. And it's also, when you think about the whole definition of trauma, it's how the person that experienced it takes it in as well. So that plays a part too, which is difficult to measure, I think.
So with the behavior for suicide, that some of these behaviors are smoking or obesity are more not consciously, that person doesn't think, well, this is because of my early experiences. A lot of times it's a very unconscious link, but in research we just know it's a greater risk for them. So it's not, if you experience 6 ACEs, it doesn't mean this is all going to happen. We just know there's an increased risk, and knowing that helps us as professionals to do interventions differently, adjust our approach so that we can better support somebody and prevent. We'll talk a little bit with trauma-informed care. It brings up very good discussions, and that's, again, where trauma is a complex issue. Adverse childhood experiences are a complex issue. They're not a simple problem with a simple solution. You could refer to them as more of a wicked problem, where it's multi-dimensional. So if we're going to make any ground in supporting or preventing, we need to hit it with really high leverage solutions that are multi-dimensional too. And we'll talk about that, because it's so complex and a lot of factors play into different things, and you're working with other humans who are experiencing things. We all have an individual perspective on our world, and the world around us. So good to just, it's a snapshot. It tells us something and we can talk about it and think about it, and these are all just great conversations. That's what we're hoping to stimulate in our community this fall, is some of these conversations and starting to look towards action too. Well, what can we do about it? So there again, that's the triangle. We're going to use this as kind of the model of looking at each piece and connecting with it. But this is the ACE, what we have gained from that study. So trauma-informed care comes along because it's, so now what do we do? Trauma-informed care is what do we do about it? And it's an approach. I think it's easy to misunderstand what trauma-informed care is. That's a common buzzword if you're in this field, in this area of to be trauma-informed, providing that work or providing an environment that's trauma-informed, and it's an approach. It's not a one and done, come to this training, one and done, come to this presentation, and now go out and you are trauma-informed. It is a continuous journey. It's an approach. It's a change in thinking, a change in talking, and a change in action. So I think it's like if you're looking through a kaleidoscope, you got all those pieces in there, and you can see a picture, and if you just adjust it, you still got the same pieces, but you got a whole different picture. So trauma-informed care is just taking those same pieces, but we're going to start looking at it differently. And once we look at it differently, we see something that's different, so then our actions then are different. And we can be more accurate in our interventions and possibly earlier interventions, and then we can hopefully prevent and provide a better environment. So it's just an approach that I think it's a new perspective of thinking. So it's an approach to engaging people with histories of trauma. It recognizes the presence of trauma symptoms. Again, it's that the behavior becomes a symptom, not the problem. We still need to address it, but it's more of a symptom. So we attack it a little bit differently. It acknowledges the role that trauma has played in somebody's life. So a little definition of it. I like this saying. It reminds me, it helps my perspective when working with somebody. It says all individuals in many respects are A, like no other individuals, B, like some individuals, and C, like all other. Because it's true, trauma-informed care is not a one-size-fits-all. It's not a checklist, now we're good, or it's not just a way of, I learned individually what I can do to be more trauma-informed care, because it all has to ride on the other person who I'm interacting with. And trauma is really a one-size-fits-one. You can do some universal strategies across the board. You can work on your environment. You can change training, leadership in this area. Some of these are really good and can be used across the board, but it also has to be individual too, on meeting that person where they're at with the skill, capability they have, and really trying to foster resilience. So it just reminds us that our perspective of ourselves, other people, and the world around us is really unique to my experiences and how I interpret those. So when I'm working with somebody as a professional, I need to remember that, which is hard to do. It's easy to say, well, walk in somebody else's shoes, but it's hard to do because we have our own view, and our view is the right view, because that's what we experience, it's what we know. So it's taking a step back and really kind of placing the other person in the driver's seat instead of us as professionals and going at their pace. So it's a different way of doing it, and there are some things that we can do when we're looking at trauma-informed care, a different approach for working with somebody, but I think we need to remember something like this. So I have done with Cindy, and Tammy Anderson is another person on our team, as well as Jane works with the National Child Protection Training Center, teammate of mine. The four of us have been searching the trauma-informed care world, and there is a lot out there, a lot of principles, a lot of people are working on this in our country, talking about ACEs. You heard the state conversation that's happening, and so there's a lot of principles and there's a lot of frameworks, and you can get great information, needed information, but boy, you can get lost in the information because there is a lot. So I just put up one. This is just 7 principles. A lot of trauma-informed care, if you were looking to say, well, how can I better work with people who have adverse childhood experiences? What can I do? What can my organization do? What can my community do? These are community level discussions in a lot of places. You can look at these principles, and I could read them and say, well, this is what we have to do, and that's what we do. But all these principles and the frameworks, 7 lists of what can be done, are just words, just principles until you put the action behind them. And a lot of places, that's where the knowledge kind of stops. There's some, but it's a lot of, we'll use this framework and checklist. And so what we try to do, and what we want to do in our community, is start using these and doing what's evidence-based and working with that. But now let's do some of the action and start getting some things done and put into place. And that's where in our community, like we said this morning, where we really want to go. And hopefully still go. The leaders are just 7. They're good to know and good to, there's a lot of good resources out on the web at different places that you could use to kind of guide your practice or guide your actions. But what we want to do is really kind of simplify it and bring it down and think, well, here in our community, what can we do? And how do we do it? How do you do trauma-informed care with an issue that's so complex, like trauma, that's so prevalent? And a lot of people have experienced ACEs and intergenerational. So we see parents who, or as a child, they experienced it, they adopted those risky behaviors, and now they have kids. And a lot of those risky behaviors are ACEs, which then just continues. So it's a very vicious cycle that continues. How do you interrupt it? How do we do that? Wrap our heads around something that can be so overwhelming. And a couple different frameworks, and what we framed it down is the things above, and we'll talk about a little bit about resilience and how we can foster that. But trauma-informed care, how do you do it? I think it has to start with our knowledge and our understanding. So that's why we have to talk about the ACE study, what we've learned from it. We need to get everybody in our community or majority aligned in our knowledge so we can start the language and we can start the actions. I mean, that's foundational. We have to have an educational base. Like I said, some have never heard it. Some are doing it already. Our perspective is key. Trauma-informed care is it's a shift in your perspective, in your approach, in your way of thinking and doing. And we need to switch that. We need to switch the kaleidoscope and change it and look at it through something different. Language will drive behaviors. Think of your staff meetings or in your break room. What's the language in there? Is it productive or is it not helpful to the organization? Language will drive the behaviors. Once they walk out of there after that discussion, will drive our behaviors. So talking a trauma-informed care language is a piece of this as well. And then our actions and our environment. And it promotes, ultimately our goal is to promote healing. So think of a forest fire. Forest fire comes and wipes out the trees, bad forest fire. So what do you have? The landscape is different, it's changed. It can represent a traumatized life. The tree could still be standing, but it's scarred. Things are different. And then what happens over time?
New growth.
It grows. And that's where there is hope. It's not early death of 20 years. A lot of things can happen that can buffer or protective factors to change that, but the green comes back. It doesn't come back the next day. And change in these type of brain changes is not gonna happen in the next day, but we can really work at it slowly and make a change and focus on growing the green and bringing it back. It also doesn't erase it. You could probably, well, you can go back and you can say, wow, a forest fire happened here. It happened. It's not, the goal is not to erase it, but it's recognizing it happened and it's making the meaning out of it to grow and move in a productive way. So that's the focus. The goal is really that healing and providing hope. And we do that a little bit through resilience. We'll focus on resilience. And this is something that's not just known, it's a skill, being resilient, the ability to bounce back from adversity. And what's the difference? So somebody, you can think, you probably know someone who has had a lot of ACEs in their life, they've experienced a lot, yet they still function really well, or they seem to enjoy life. They seem, they, according to the research, they should be in jail, but they're doing really well. What is that? And that's just as there's been as much research on ACEs and trauma, there's been a lot of research on how do we build resilience? How do we do those two things, work with this, but also build that ability to bounce back, that ability to do well? What is that? What lies in there? And how can we foster that? Through trauma-informed care, we're going to foster that. But it's something that's learned and something that we can grow and develop. All of you have experienced resilience. Think about in your early childhood, someone who taught you something about resilience. They modeled something for you. They had a saying that has just stuck with you. Somewhere along the line, you have learned traits of being resilient. And there's traits too that people have, like a good sense of humor, being able to be flexible. There's identified traits that also help with resilience. And we can grow those. We can see those in people, and we can help foster those. So last thing, just to frame our thinking, I think another thing with trauma-informed care is we have to think of it in a layered approach. Individual, has to be individual because we all work at some level and we interact. That relationship is key. So there's things we can do on an individual level to make changes just with how we choose to interact, our approach of how we see the behaviors. If it's a really baffling or challenging behavior and we've been stuck in working with this, now we got to change our perspective and we can look at it a little bit different. I'm just going to pass just a checklist. This is just used by somebody. It's just a simple, quick individual intervention if you work with a population, kids or adults, and you can see how you're doing. It gives you just a framework of where am I as an individual for an approach. But you have to have all of these, because have you ever been frustrated when your organization isn't changing as fast as you want it to change on any policy, any issue? As you start in the middle with individual, you can make changes quickly. You could change tomorrow how you choose to respond to a challenging behavior, how you choose to respond to a situation, change quickly. As you go out to organization and to community, that's going to take more time. But we need to work at all these levels. What can an organization do? Leadership needs to be involved. We can change our environment. What can we do to make the place more welcoming? How can we provide staff training to everybody? Different things you can do at an organization level. And then as a community. We're moving that way. And the community comes when the individuals start and then when the organizations. Then we expand out when we finally have a community level train. So it has to be connected. It has to be at all different levels. And that's what we're hoping to be able to work on as we continue the journey this fall, is to start building some of these, increasing knowledge, increasing our common language, increasing our skills and what we can do at an individual level or an organizational level and then community. So we have, we'll pass out the training flyer on different things that we often, you want to talk about at this time?
Sure.
It's through the United Way Venture Grant support.
Whoa. Whew. So, as Lacie said, we did apply and were awarded the venture grant through the United Way. So we're doing some additional trainings this fall. We're hoping to, again, raise awareness and knowledge of the ACEs, because that really is the foundation. Work on coming together as a group to strengthen that work. Looking at some of the protective factors in the community that we can change and work on to build those better brains. Using the data and the results, so as Lacie kind of talked about the survey amongst the high school students and looking at that to make changes. And then public and private-based strategies and tools, really trying to pull that all together and get that information out there. So our program is called From Trauma to Resilience, Fostering Hope Through Trauma-Informed Care. Again, looking at that, kind of laying the foundation and teaching everybody about the ACEs. So even at Gundersen, like I said, we started this work in the behavioral health world in 2012 before we opened our new building. So we trained all our inpatient staff. Then we made the changes in our environment and built that new building. Now we're spreading it out to the providers throughout the whole institution. So we're talking to general medicine physicians, we're talking to family practice, really what I would consider kind of the community, and getting that information out there. We talk in our training too, we'd go into more depth about those physiological changes that happen in the brain. We talk a lot about the amygdala, and we talk a lot about the frontal lobe and things that happen there related to the trauma. Looking at trauma-informed care and its impact on your work, and then a lot of the day-long information that we're going to provide is giving you some strategies to put that into practice. So these are kind of our concepts, and again, when you think about the strategies that we're going to use, this is what we're really basing that on. So building relationships. And our training that we did at Gundersen, we talk a lot about healing happens in relationships. You have to build the relationships because people aren't just going to walk in and kind of share all of these traumatic experiences with you. So building that relationship helps you to kind of see those things and identify those ACEs. Working on building coping skills. Something, again, we've done in behavioral health is now we've taken it the next step, and we're doing a lot of work with sensory tools to help manage those symptoms of distress and those behaviors that kind of come out. Creating a positive learning environment. Also looking at self-care. So when we talk about trauma in the sessions that we provide, we also talk about vicarious trauma. So the trauma that we experience by interacting with and taking care of these people that have a lot of these things that have happened to them in their past, and how you need to take care of yourself in order to help them. And then again, that community effort and different things we can do as a large group to make the changes.
So on the flyer, we kind of have detailed what we're able to provide is we have basic training, which is just like a two-hour training that focuses on the knowledge. We follow the ACE triangle, but we go more in depth in each area. And then the advanced training goes that next step of what are some actionable items we could do, some small steps we could take as an individual, organization, and then all together a community. And some of these trainings are available on site. The advanced, basic and advanced are available on site. The advanced training is for up to 25, where we start to take them through that action. And we have they're kind of on a first come, first served basis through what the grant is able to support. And then the September date and the December date that are listed on there are ones that we're hosting at Gundersen. So individuals could sign up from all over and do an advanced training, but it will be at Gundersen. And that registration should be open today on those. But it's up to 25 at each the September one and the December one. Same training, but they're 25 in each. So, yes.
If you would do an advanced training at a different facility, is there a limit to the number of persons?
25.
25.
Because that one does, the basic is just the information, it's more of a lecture style, and just to give people the knowledge of it. And some organizations might need that because they haven't had this exposure as much as others. And the advanced one has some of those more interactive discussions and strategies, so we limit the number. And my contact information is on the flyer. If you have questions on it or framing it, please contact me, and I can explain it to you to try to meet what works for you and your agency. But
did you say the Tuesday, the 15th of September and December 7th, those are advanced ones?
Yeah, an all day, 8:30 to 4. We also are able to offer lunch and morning refreshments too, which is kind of cool. Bonus.
Yeah.
Did you get a sense of what the high school might do with that information that you gathered?
The youth risk, they all have it available, and I know, well, even they're doing work, community level work and individual work, like, you know how I look at you for alcohol and tobacco, because I know you've worked in that world for a long time, our resources, and I think more and more resources are going towards what's noted as trends, even in our schools. That's another key piece too. With this, what we hope is to pepper these trainings in different sectors of our community. So it's not just our schools, but our schools can now talk common language with other places like Boys and Girls Club, because if we have the same training, we're not alone in this at all, but we're working together at so many different sectors that we have. But it's good question for them. I know they look at it and I know they use it and try to develop, areas of support where needed, where noted.
Would you say that someone should attend the basic training before they would go to the advanced?
The basic's kind of within the advanced, because we'll kind of do the same layout. We just then can take it a little bit further because we have more time. And some might be more ready for that, to talk about different things we can do. Others just might. Sometimes the information itself is an aha of, wow, I didn't know that. This changes a lot of things for me.
It's
So
not a prerequisite.
yeah, we tried to have things that could meet that continuum of need with I just need information to, I'm ready to start talking about what we can do. So, which was challenging because we are all at very different levels, but it's another step forward our community is making, and it won't be the last. It's just for this fall, this is an opportunity we can all work on, and we're in this just as much as you are as a participant of the conversation. We'll just be facilitating the conversation. So, thanks for coming. I think we're right at, I don't know if they're meeting. Everyone's just kind of done, right, at 1:30? So we will close off the day for you. Thanks for coming. If you have any other questions, let us know.